Succes i veterinær praksis, podcast nummer 77. If you're here for Dr. Susan Little, don't worry, only the introduction here will be in Danish. The rest of the interview will of course be in English. Jeg hedder Søren Pejstrup, jeg er dyrlæge, og jeg har bloggen Succes i veterinær praksis. Det er et e-mail-nyhedsbrev, den her podcast, du lytter til nu, og en serie online-kurser, der alle sammen fokuserer på at levere komprimeret læring til danske dyrlæger, sådan at vi kan få noget faglig udvikling ind i hverdagen, uden at det tager tid væk fra både klinikken og familien. I dag skal vi snakke med en af verdens førende eksperter på katte-medicin. Jeg har fået fat i Dr. Susan Little, som ved rigtig meget om katte. Hun har de sidste 20 år udelukkende beskæftiget sig med katte. Mange af jer vil kende hende, fordi hun holder en hel del foredrag rundt om i verden, og har for nylig også været i København. Spørgsmålet, som vi kredser om i dag, at jeg har fået fra dig, der lytter til podcasten herude. I er nemlig rigtig søde til at skrive mails og svare, når jeg spørger om, hvad I bøvler med. Og her snakker vi så om indgangsvinklen til det her med kattemedicin. Der er naturligvis masser af andre ting, vi kan grave os ned i. Hver enkelt diagnose, hver for sig for eksempel. I dag der tager vi ligesom det store overblik om, hvordan at Dr. Susan Little, hun ligesom lukker op for boksen her med alle mulighederne i. Der er links og noter som sædvanligt over på hjemmesiden i shownoterne til det her afsnit. Det er nummer 77, så det finder du på sivp.dk/77. Og så over til interviewet med Dr. Susan. Hi Susan, and welcome to the podcast.
Thank you very much. I'm so happy to finally get a chance to talk to you.
And thank you for being here. I think you're a very well-known expert because you give a ton of lectures. So a lot of people out there will know who you are. But you are a very well-known cat expert in our field. But can you please give a short introduction and tell us a little bit about your background?
Sure. So, yes, I am a cat specialist, and I've been in feline medicine exclusively since about 1990. So what is that? 28 years, I guess.
Yeah.
Only working with cats. I knew when I think even during veterinary school, I knew I would want to work mainly or only with cats. And then I got that opportunity about 2 years after I graduated. So I graduated in 1988. So I have been a vet 30 years this year. It hardly seems possible. It's been that long, but it is. And for 28 of the years, only for cats. I own 2 practices that are just for cats, and they're in Ottawa, Canada. And I still spend some time there, but I spend a lot of time, as you mentioned, teaching now, doing lectures and doing workshops pretty much all around the world.
Yeah, and you spent time in Copenhagen earlier this year. I didn't see you there, but you told me so.
Yeah, I was very lucky to be in Copenhagen for a couple of days for a conference that it was right at the beginning of March that Boehringer did, called their Feline Inspiration Days, and it was a lot of fun. I love Copenhagen.
Thank you, but yeah, well, the weather isn't too good in Copenhagen that time of year, but I hope it wasn't too bad for you.
It wasn't too bad, no.
Thank you.
People are so nice.
Well, thank you. Yeah, well, I don't live in Copenhagen, so maybe it's not my place to say thank you. But,
well,
anyways.
I think just in general in the country, people are. I have always found people. Maybe it's the veterinarians, but in general, I think people are very nice in your country.
They're good to know. So I, from time to time, ask my audience what they struggle with and the pain points and so on. And one has mentioned, one in particular has mentioned a pain point she has, and she wants to know what do you do with a cat that is anoretic, or maybe is just a little bit depressed, or I think the term is under the weather. In I don't know if that's an English term or if you use that in Canada as well, but
yes.
And I have myself in the clinic where I work, I have a saying. So if a cat comes in and is not eating, I tell the nurses it's never a tooth problem. So a cat that is not eating, you should look for something else. Never just anesthetize the cat and do dental work on it. Find out why it's not eating beforehand. And I think the nurses are getting tired of hearing me say that. But anyways, so this basically revolves around the same kind of issue or same question. What is your clinical approach to a cat with subtle clinical signs? Or how do you actually open the box up on this one?
Yeah, I think it's a good thing to talk about because it's a very common clinical scenario. And I'm so glad that you mentioned dental or oral disease in those cats. Of course, we want to do a good oral exam and look for problems. But I think you're very right in that it would be unusual for a cat to stop eating simply because of oral or dental disease. Maybe an oral tumor in an older cat, yes, but we do see a lot of dental disease in cats. It's very common, yet it would be very rare for that to be the reason for an anorexic cat or even decreased appetite. And so I'm so glad you mentioned that because it seems a natural assumption that we would think about treating dental disease as the cause of the problem. And of course, the dental disease, if it's present, does need to be treated. But it would be a mistake, I think, to assume that it was the cause of the decreased appetite. So if your saying in your clinic is about the teeth, one of my favorite sayings is that cats only have 4 clinical signs, and they use the same 4 clinical signs for every disease. So every disease in cats, they have anorexia, they have lethargy, they have vomiting and diarrhea. Every disease, it seems, it's the same. So, excuse me, it's allergy season. They're often a little frustrating because they do seem to have very often non-specific clinical signs. And, I have 2 dogs in my home, so I know what dogs are, but I don't treat dogs as a veterinarian. So I hope they give more specific clinical signs than cats because that's very common in cats. So you always have to approach these cats with a very wide open mind that it could go anywhere, and you could go down any path with these patients, and not just focus on the teeth, as you say.
Yeah, well, and some of the times the owner comes in with a very specific idea on what this cat has, and then it's been not been eating for a couple of days, and they have decided in their mind that it's a tooth problem, or they cannot pee, and they have decided it's a bladder infection, and
right,
and then we have to do a little bit of communication here because 98% is something else, and then we have to try to educate the owner as well before we can even start talking about the disease.
That's a really good point. So I like to teach in my lectures that what you want from owners are their observations, but not their conclusions. Owners, as you say, often like to, or they've come to their own conclusion about what's going on with their pet. And so when I hear that from them, they might be right, but they may not be right. And my job is to make my own conclusion about how we're going to approach this cat. So I like to move the conversation back a little bit and say, tell me why you think that, or tell me what you have noticed. Tell me about your observations, because that's really what we need. And that is part of the art of getting a good medical history, is learning to get observations from owners, not conclusions.
And that can be actually a challenge. But you mentioned diarrhea, and this might be a tangent, I don't know. But I used to ask owners, how does the feces look like? Or what does the feces look like? And they will try to come up with all sorts of answers. And I try to shift the question, or start by asking, have you seen the feces? And oftentimes the answer is no. And then suddenly I get a more honest answer because I haven't seen it, and I don't try to make up something they thought they might have seen.
Oh, I think that is a wonderful comment. You and I should do lectures together. We think the same way.
I don't know.
I just finished doing some lectures over the weekend, this past weekend, and I talked about this. And I love your observation that first you need to ask if the owner has seen the feces. It may not be the owner who brings the pet to the clinic, may not be the owner who is in charge of cleaning up after the pet. The other thing that we started to do a number of years ago, from the same sense of frustration of getting information, I don't ask owners to describe the feces anymore. We have a chart. Most of the food companies make a fecal scoring chart, and it has pictures and descriptions and a fecal score. And so we use that chart, and I show them the chart with all of the pictures, and I say, tell me, point on the chart, what most looks like what you see at home from your cat. And that I find is an easier way to open up that discussion, because one thing we discovered when we started doing that is a lot of people don't know what diarrhea looks like. And they may tell you the feces are normal when they're not. And in fact, I lecture about a case where that exactly happened to me, that I accepted the owner's observation that the feces were normal, and in reality they weren't. And it was the key to solving the case. So that, I think, is such an important point, developing communication tools and strategies so we get the good information.
So does that actually circle back to the original question? Is that is one of the keys to the clinical approach to these frustrating patients?
So I believe that we cannot replace a good clinical history on our patients. Even though it seems almost every year we get new tests, we get new tools, and I see younger veterinarians who would prefer to take a very short clinical history and immediately start running tests, as if the answers are always in the tests.
That's me.
But in reality, we need the tests for sure, but you cannot interpret them appropriately without a very good clinical history. And I think it takes practice, it takes learning communication skills, and it takes patience to get a good clinical history. We will never replace that, I don't think.
No, but yeah, I'm trying to shift away from that way of practicing. But sometimes I take these blood samples and I scratch my head, and I'm trying to call the laboratory and ask them, where is the answer to the mystery here? Where do you write what the disease is? This is I can't see it anywhere on the blood sample.
We need to be careful when we talk to owners and when we run blood work, especially our typical complete blood count in a chemistry panel and a urinalysis, for example. That is a first level of testing, and we may or we may not find clues or the answer from that level of testing. So it's important to have correct expectations about what we will get from that testing, both for us and for the owner. So a good example of a class of diseases where you often don't get clues, you might not get clues on routine blood tests, are gastrointestinal diseases. So inflammatory bowel disease in the cat, for example, very common disease, and you can have perfectly normal blood work for that disease. We also, I think, underestimate the effect of stress on cats and the ability of a stressful home environment to cause clinical disease. And that won't show up on blood tests either.
No, and then it actually comes back to asking the right questions.
It does. And so I think many of us forget to ask questions about the home environment that the cat is living in. Are there other cats in the home? What's that relationship like? If it's a multi-cat home, is there a food and a water bowl for every cat? Does every cat have a place to sleep by himself? How many litter boxes? Sometimes the answer is in that home environment, which could be very stressful for the individual cat. And we know now that chronic stress, even sometimes short-term acute stress, can cause clinical signs of anorexia, vomiting, diarrhea, even short-term urinary tract signs. These can all be driven by stress and not necessarily by organic disease per se. And I think we underestimate that.
But if I come out and say to the owner, I think your cat is stressed, many owners would object to that. Well, he's not stressed. He's lying sleeping in the window, and or he's playing with the other cat. So I don't think he's stressed.
Yeah, I think you're right. Both veterinarians and owners have a hard time understanding what stress, or probably distress is a better word, what distress looks like, especially on a chronic level in a cat. So I won't say that at the beginning. I'll just start asking questions about the home environment. And there are a few key questions that you can ask. In a multi-cat home, a good question to ask is, how often do you see the cats sleeping side by side, like touching each other in close contact? That's often a clue to which cats get along and which cats don't. So for an example, in a home with 3 cats, there may be a pair of cats who get along well, and then one cat that you never see sleeping side by side with the other cats. And so in that home, there's actually 2 groups of cats. And owners won't think of them that way. They won't think of 2 groups that each need their own attention, their own resources like litter box and food and sleeping places. So a lot of it has to do with educating ourselves about those environmental needs and feline behavior, and then translating it to the owner.
So that is so that is the home environment, and we talked a little bit about the gastrointestinal tract. Is there anything else you focus on in the history?
Well, the other thing that is very frustrating in medical histories, especially for cats, is finding out not just what kind of food the cat is eating, but how much. Most owners don't know how much food their cat actually eats, because it's very common for owners to simply leave out a bowl of dry food and expect the cat will eat when it. And so actual food intake can be very hard to determine. So sometimes I will start with that, and I will ask the owner to go home and measure food intake for the next few days, and then let me know what it is. So I might ask them to weigh the food bowl in the morning and weigh it again in the evening, for example. And then that way, over a few days, we can get an estimate of food intake. Therefore, we can calculate calories from that and give us an idea if the problem is actually decreased caloric intake. So that gives us another concrete piece of information.
And how would you do that in a multi-cat household?
In a multi-cat household, of course, we'll have to ask the owner to feed that one cat separately for a few days. Sometimes we find that actually solves the problem, that maybe there's been not enough food bowls in a home for the number of cats. And one cat is preventing another cat from eating. And I think all of us underestimate how good cats are at intimidating another cat with only a look. You know, no physical violence, no noise, just a look. They're very good at that. And most owners don't notice that. So they may actually have one cat who doesn't get to eat often enough because another cat is protecting the food bowls. And then when they feed that cat separately, then all of a sudden he starts eating normally. So sometimes it turns out to not just be a diagnostic tool, but it turns out to be the answer. You know, cats as a species are not a group eating species. Dogs are more behaviorally adapted to hunting as a group and sharing what they catch. But cats are individual hunters and individual eaters. So if there is any problems amongst the relationships of cats in a home, often one of the ways it's manifested is in this distress around having to eat in public with or around the other cats, because that's really not natural. You know, if a cat went to a restaurant, he would order a table for one.
Yeah.
Yeah,
so
he would not eat with his
Cats,
friends.
if we were cats, we wouldn't have invented McDonald's.
No. And you know, we like to socialize around food. We get together as people with food. It's a social event. For cats, food is not a social event. It's a very non-social event. And they would actually, many of them prefer to eat alone. So sometimes we just have to try to adjust the management in the home or the environment in the home to allow the cat to do what biology, what nature tells him to do. And nature tells him to do some things with his friends and some things without his friends. And one of those might be eating alone.
So if we give the owner some time to give us all the details, and we give ourselves maybe some time to listen to all the details, then we will usually start by, at least where I work, we will start with the clinical examination. Is there anything in particular you are specifically focused on, or is it just maybe just the normal stuff?
Well, it is the normal stuff, but it depends on what you mean by normal. So, for example, I think for every cat, but especially one with the complaint of not eating well or weight loss, is that we do body condition scoring and muscle condition scoring, and that we weigh the cat at every visit. And I find that many veterinarians will not be concerned about a small amount of weight loss in a cat. And if the cat is otherwise well and the owner did not bring him in for a health complaint, maybe it was a vaccination visit, for example, and it's less than, let's say it's only 5% weight loss, that may be simply something to monitor. But you know that most of the time we struggle to get cats to lose weight. That's a difficult thing. Mm-hmm. So when we have unexpected weight loss, anything from about 5% or more that's unexpected, and that may just be 100 or 200 grams. That may not be very much weight loss. That should be investigated. That's a clue. And a lot of veterinarians might not realize that even that small number of grams of weight loss is significant in a cat. So I would never ignore that. And in our practice, we also muscle condition score and body condition score patients at every visit. Yeah. So these are useful pieces of information.
There was actually a PhD done in Copenhagen on the body condition scoring.
Yes, I know.
And she found out that we cannot, your body condition scoring isn't very much compatible with my way of looking at things, but it's very uniform from within the same vet or the same observer. So you can use that to grade the cat from one visit to the next.
Yes, and we as veterinarians, we tend to be, most of us would agree on identifying low body condition score and high body condition score. It's in the middle, the numbers in the middle where you may give a different score than me. But you're correct. We do tend to be consistent within ourselves. So, and within a practice, as you know, there's 2 body condition scoring systems, a 5-point and a 9-point. I think every veterinarian in the practice should use the same system. You should agree that you're going to use one versus the other. And then recognize that you might get some small variation from vet to vet, but generally we're consistent amongst ourselves. And so we also get better with practice too. If you do that for every single patient, we do it even on a vaccination visit, then you get better at doing that. So sometimes the clues are there in front of you in the weight, in the body condition, in the muscle condition, in the fecal characteristics, in the information from the owner. We just have to work a little harder to get them all. So often when I find myself confused by a case, I don't understand what's going on with the cat, I will go back to the beginning and look at all my information from the beginning to see, did I miss some critical piece? Was there a question I forgot to ask? Did the owner say something that I now need to ask more about? I'll go back and look for those gaps in the data that I have.
And you mean years back, or?
Well, no, let's say within, if I'm currently working with a patient that is not doing well, and he's coming back on the next visit, and I'm still, unsure of what the problem is, I might go back to the previous visit or the visit before that and look and see, is there something I didn't pay enough attention to? Do I need to ask more questions? And then sometimes we just need to go to the next level of testing, because the basic laboratory analysis most of us do, the complete blood count, the serum chemistries, the urinalysis, give us a lot of information, but have limitations, of course. So we may need to do some specific gastrointestinal focus testing, for example, or we might need to do some imaging. So I think we have to prepare the owner and be prepared ourselves that this might be a stepwise investigation, and we may need to move from the first step on to the second step. So I do see a lot of cases from veterinarians where they have difficulty moving to the next step, moving themselves, their thinking, and then also preparing the owner that they need the next step. They need they need new tests. Maybe they need an ultrasound. They need that next step. So I always try to think of it that this is a road that we might travel a short distance to get our destination, but we also might have to travel a little bit further. So keeping that open mind and preparing the owner so they have a realistic expectation of where this might go, and not make them feel like, if you pay for this set of tests, I will have the answer. because of course it's not always true.
and I have to be completely honest here, because this is actually what I have done, or I still do actually, is sometimes money also is a part of the discussion. And people will, for one blood sample, we will find the money for one blood sample, and we do one blood sample, and then there's the answer isn't there. So if just from the start I haven't been too clear that the answer, that there is a possibility that the answer isn't there, that we might have to do something else to get the answer.
We have to be honest with the owner when we do that initial set of blood tests that we may not get the answer from that set. And I also think we need to be thoughtful. If the owner has only a limited amount of money, what will we spend that money on? Maybe you routinely submit samples, let's say, for a complete blood count and a chemistry profile, and then a urinalysis. Maybe that's and that would be a common set of tests to order. But if the owner only has so much money, for that individual patient, you will say, okay, I don't think the urinalysis is the most critical part based on the patient. But I always make sure the owners know we're working without a diagnosis. And I also make sure they know sometimes that's a more expensive way than actually spending a little bit more money on the diagnostics, because you can also spend a lot of money on therapies that don't work when you don't know what the answer is.
Yeah, for sure. And do you order anything else in particular? I'm wondering, how about T4? Is that
yes?
That is obviously relevant for an older cat, but is that
yes.
a basic database for you?
Yes. So certainly, by the time cats are at least 8 years of age, we will always include a total T4. The other thing that we do, and again, starting around 8 years of age, is we do a blood pressure assessment on all of these cats, because high blood pressure is not uncommon in cats at all, and can have very vague clinical signs. Like every other disease in cats, it can have quite non-specific clinical signs. So it's important to not just think about your workup for a sick pet, but specifically for a cat that's middle-aged or older, to recognize the value of the T4, of blood pressure assessment. And another test that I will often run when we have very non-specific clinical signs is a serum cobalamin, serum B12, because serum B12 is decreased with many gastrointestinal diseases in cats. And that can be often a less expensive gastrointestinal investigation of the other tests, and might give us a quick idea of if the problem is localized to gastrointestinal.
Is flotation very important or very relevant in this workup?
That's a great question, because I think that's where assessing your patient's lifestyle and signalment becomes important, and might trigger you to do testing like a fecal flotation. So younger cats with intestinal parasites are more likely to have clinical signs from it, but older cats, not so much. So that would be something I would want to do for a younger cat, a recently acquired cat, a cat with outdoor access, for example. But once they get older, we see lower rates of parasitism, especially if they're, depends on their lifestyle, of course, but also just less clinical signs often. So I think that's where taking your patient's signalment and lifestyle into account becomes very important.
And that is a part of the specialized GI testing that you mentioned?
So we can do, I wouldn't consider that specialized GI testing. What I was thinking of more in that regard are these blood tests now we can get for pancreatic disease, so the feline PLI, the pancreatic lipase immunoreactivity, the TLI, cobalamin, folate. So you can get those often as a panel and sometimes as a whole panel. It's useful but expensive. Whereas if I need to save money or I want to just have a quick idea, maybe if gastrointestinal disease is an issue, I might only do the serum cobalamin to start with. I think we underestimate the diagnostic utility of serum cobalamin in cats. It's decreased in many GI diseases, chronic pancreatitis, inflammatory bowel disease, lymphoma, all common problems in cats and often associated with decreased serum cobalamin. So at least then we know which body system we're focused on when we see that low cobalamin.
And that will actually help a ton just to know what organ to be aware of.
Right. Often we're starting, again, you have to start with an open mind because cats have so many non-specific clinical signs. Really our next step is which body system, not which disease yet, which body system. So being thoughtful about how you use your clinical investigation can make that a little bit easier road. And that's, again, where we often use serum cobalamin to help us look at the gastrointestinal tract. Now, you can have gastrointestinal disease with a normal serum cobalamin, of course. But if you do get a low value, that's very useful in localizing to one body system.
And how about FIV and leukemia virus testing? How often is that relevant?
So that is one of my special areas of interest. And I think that's another set of diseases that we underestimate. And it is typically part of the diagnostic investigation in our clinics for most sick cats. So even if they had been tested previously, unless they were just tested last week, if it was last month or last year or some other year, it's no longer relevant today. So we do need a current test for feline leukemia and feline immunodeficiency virus for a whole variety of reasons. There's many reasons why that is the case.
And that might be a whole podcast in itself.
Yes, it's one of my favorite topics. So it's really important not to forget that. I find that is commonly forgotten. Maybe the cat has been vaccinated for feline leukemia, and so the veterinarian thinks, it's not possible to have the disease. Well, there's a number of reasons why that's not true. So even in a vaccinated cat, we would always want to know the status for those viruses.
Yeah. And I have a ton of questions on that, but I think we will we'll have to save them for some other time because I find that area very interesting as well. But I don't think we should go down that rabbit hole right now.
Yes, it deserves its own time.
For sure. How about, you mentioned imaging as well. What do you start off with?
Well, it really depends, I think, on the patient and if there's any clues at all that they can give us. So if we have very little clues, often we will start with survey radiographs, chest and abdomen radiographs. Because they're usually cheap. It's the cheapest imaging, typically. Typically we can do it quickly. So often we'll start with that. But if there are any specific clues, if I have any concerns on abdominal palpation, for example, we might also think about ultrasound. And I find that veterinarians sometimes think that it's either radiography or ultrasound. But very often, the two give you different types of information, and you might actually benefit from both. So it's not necessarily one or the other. If we have musculoskeletal disease, for example, arthritis or a bone fracture or some other bony disease, then radiographs are better. And of course, we can think of situations where ultrasound is better. But for a lot of conditions, especially for chest and abdominal imaging, we may, many of our patients, we end up doing both. So I think that's another thing to keep an open mind about, that you might pick one imaging modality initially, but your patient might benefit also from the second modality as well, depending on what's happening.
And I think also that comes down to the clinic. A lot of the smaller clinics here in Denmark, anyway, will maybe have equipment for doing radiographs and might also have an ultrasound machine, but it's a more steep learning curve. And if you take the radiographs, you can submit them for evaluation some other place. So that's more difficult with the ultrasound. So that will more often than not be referral work to send the patient off.
I agree. And you should always, in your own practice, you should always use the modality that you are most experienced with, provided it's not contraindicated, obviously. But you should use what you do the best. So I would rather a veterinarian take radiographs than use ultrasound if the machine is not good enough quality or they don't have enough experience interpreting the images. I would much rather they use radiography, where most veterinarians are more comfortable. And as you say, it's easy to submit just the images to a service and get an opinion than to try ultrasound if you have, equipment that's not so good and you don't know what you're looking at. So, of course, we use the tools that we have at hand and the tools that we're most familiar with.
So we could actually go down any other way here. We could talk about most of the differentials in the book here with this approach. But do you think there's anything else that we have left out that should be in here?
I think we've covered most of the important things. We've really covered a lot, making sure that we do have a complete history, and that we've not allowed the owner to give us a conclusion that may or may not be correct, that we've evaluated the home environment and we've looked for clues there, and that we've done obviously a good physical exam. I think cats are often more difficult to do a complete physical exam than dogs, and many veterinarians are still have less skill, I think, or more trouble when a cat is difficult to examine. And so I do see also a lot of cases where the veterinarian is able to get blood and urine tested, but they're actually not able to do a very thorough physical exam. So we can't skip over that step. And we may need to use some sedation for that patient. Sometimes these patients are very fearful. Sometimes they're painful. That's another area we should be careful about, because cats display pain differently from dogs and from people. So we need to be thinking about assessing these patients for pain and recognizing some of them are resistant to our handling because they're fearful or painful, and it's good medicine to offer a sedation alternative for those cats. And we have many safe sedation alternatives now, so that we do get a thorough physical exam done and we don't miss any clues on the physical exam.
So, but what I get out of all this is that actually it's when we have tough questions and we have patients that we don't understand, it's pretty much back to the basics, asking the right questions and doing a proper physical examination.
There you go. I think that's very true. And in this time of technology and an increasing menu of diagnostic tests that we can do, nothing replaces a good medical history and a good physical exam. There are clues there. We just have to be patient, and we have to be thorough, and we have to be open-minded about what those clues are. They can help you a great deal in dictating your next steps and also help you interpret the data that you get. You know, you may get blood results back with minor changes on them that in some patients you might say, oh, that's very minor, it's normal variation, it's not relevant to this patient. But in the context of another patient, that same minor change might actually be an important clue. And so you can't make that interpretation without having that excellent foundation of the medical history and the physical exam.
I think that's a very good note to end on. I'd like to wrap up here, Susan. If anybody wants to try to get in contact with you or try to follow some of your work, or maybe even find a lecture that you're giving, where is the best place to get hold of you?
I'm pretty easy to find. So on Facebook, if you just search, it's Dr. Susan Little, or if you look for Cat Vet Susan, you'll find me typically on Facebook or Twitter. So Cat Vet Susan is a good search term to use. And my website is drsusanlittle.net. So many ways to find me.
Thank you very much.
You're welcome. It was a pleasure.
Hvis du vil lære mere om det her med blodprøver, så kig for eksempel over på online-kurserne over på hjemmesiden. Du kan som altid som podcastlytter få 4 uger gratis adgang. Dem får du på SIVP77.dk/4 uger. Der er flere forskellige andre kurser derovre, men du kan sagtens bare nå det igennem på de 4 uger, og så kan du se, om det er noget for dig. Er det ikke det, så kan du melde dig fra igen, uden at det har kostet dig en krone. Jeg håber selvfølgelig meget, at du vil blive hængende, og vi har også et rigtig godt fællesskab, hvor vi hjælper hinanden med nogle af de svære cases, og det er du også meget velkommen til at kigge ind i. Også helt gratis i de første 4 uger i hvert fald på sivp.dk/4 uger. Det var alt, hvad jeg havde i dag. Husk, at du kan finde links og noter som sædvanligt over på hjemmesiden. Det er på sivp.dk/77. Tak for i dag.